morning, everybody. Good morning, everybody. My name is Dr. Mariana Tiebet. I'm the Executive Director of Merck for Mothers. But this morning, I have the distinct pleasure of introducing this panel, What's Next in Global Health? I think as all of you can see from the description of the panel, we're here today not only to figure out what the new emerging threats are to global health security, whether they be the non-communicable diseases, pandemic crises, the humanitarian situation that we have right now, but also I think to identify what some of those solutions will be so that we can respond effectively to these emerging global threats. I think we're going to learn to walk and chew gum at the same time and work across sectors, collaborating effectively to bring the best from all the innovation that we have to effectively respond to the threat. So without much further ado, I'd like to introduce the moderator of the panel, Olga Hassan. She's a staff writer from The Atlantic, where she covers gender, health, and science. She's also has been named, I think, one of the 10 best science writers from Real Clear Science. I've looked you up. And a two-time recipient of an International Reporting Journalism Fellowship. So take it away, Olga.
Hey, well, thank you guys. And thank you all for being here. So we're here to talk about global health, which is a really big topic, but there's a lot of really interesting trends happening in it. And I'm here with four people who really have different perspectives on this and have been working on this for a really long time. So first to my right is Steve Davis, the president and CEO of PATH. Then there is Mark Smolinski, the director of global health at the Skoll Global Threats Fund. Agnes Binagwaho, a senior lecturer in global health at Harvard and the former Minister of Health in Rwanda, and Michael Myers, the managing director of the Rockefeller Foundation, where he focuses on global health. So I'd just like to start by opening it up with a really big question. Whenever you guys think of global health, and everyone can answer this, sort of what's the number one issue on your minds? What's the thing that keeps you awake at night, or if you're not an insomniac, what's the first thing you think about when you wake up and think the words global health? Take it away.
Well, it kind of depends on the day, but I think we obsess, and I obsess on the number of kids and women and families and men around the world that are dying unnecessarily. And so we focus very much on the people today that dying of diarrhea and vaccine-preventable deaths, and how do we take innovation that we know exists, that our kids have access to, and ensure that there's an ability to get it make it more accessible and available to kids everywhere. And so I really focus on the here and now.
Okay, great.
Yeah, and I think for global health, and now everyone's talking about global health security, and to me, we're not ever going to have global health security unless we have national health security and unless we have personal health security. So I really think of global health as thinking about the individual and everything that they're dealing with. So while our foundation works on infectious disease and pandemics, we're really doing it in a way to think about the individuals in the communities they work with. So while we're worried about the next emerging disease or infection, we're trying to do it in the context of all the other things they're worried about, the chronic diseases, the environmental concerns, and so forth.
Okay, so I like this because the principle of global health is leaving nobody out. Meaning you look to each and every one, each and every poor, each and every vulnerable. However, what is new in global health, and also, I'm not here as a former minister. I'm here as the Vice Chancellor of the University of Global Health Equity. That's what is new in global health for me. But what is new is that, unfortunately, we are as stupid as usual. And we need to talk about that. Because I was waking up this morning and thinking about, after the First World War, the flu killed more people than the war, isn't it? Where is our memory? Global health threat.
And this is the 100th anniversary of the great influenza outbreak. At the Rockefeller Foundation, we've focused on a lot of the things that have been mentioned and are very concerned about disease surveillance, dealing with pandemics, the equity questions. We've championed universal health coverage. So those are very important, and we'll continue that work. But looking ahead, the issues that are on my mind in global health are outside the health sector. If we look at the trend lines on global health, we see a rising incidence of non-communicable diseases, heart diseases, diabetes, cancers, and those will dominate health going forward. The solutions to those are within the health sector has its role, but the solutions overall to prevent these things are outside the health sector. So it has to do with a clean environment. It has to do with how we design our transportation systems. It has to do with encouraging physical exercise and other things outside the health sector. There's a really great quote that I just love from someone many of you may know, Michael Marmot, who's one of the premier scholars on health equity and the origins of poor health. And he says, health is just too important to leave to the doctors. And so that's, I think, the future of health, is looking outside the health system for the solutions of tomorrow.
So I got to follow up on one of those, which is, Agnes, how are we as stupid as usual?
Because we don't take lesson of the past. And we are a species, a living species, with the best brain on Earth. Maybe the dolphin has as much as us. But we are not taking lesson of the past. We know what to do. We all know what to do. And it doesn't take off. There are so many goodwill around this knowledge, and it doesn't take off. What are we missing?
What are we missing?
We are missing the organization of the goodwill, meaning there are too many players that are not giving a hand to do things. Such a gathering where we put people together here at Aspen is the first time I'm in Aspen, and it gives me hope. Because it is this link that is missing that can be created by gathering like this. That kid died for diarrhea, but it should not be possible today. But my goodness, it should not be possible and acceptable today. And they are still there. That clean environment is not there. It should not be possible today. I love my country. Who went in Rwanda? How clean is it? I want to see that more. How clean is it? Voilà. Clean environment is just our hands and education. Are we not good enough to educate a couple of billion of people like us who have a brain? So that's why I focus now on education.
I want to pick up, if I could, on something Agnes just said about we know what to do. In so many cases, we do know what to do. Sure, we need financing. Sure, we need better community health workers and the like. But what it comes down to so often is political will to push forward and get these things done. And that requires some encouragement or pressure from the citizenry. We at Rockefeller Foundation, as part of our health work, are doing more and more with civil society organizations around the world. And we have a coalition now of more than 800 organizations in 117 countries. And they are focused on encouraging their own political leaders to push forward on health, to invest more in health, to really reach the last mile populations, to do better on pandemic preparedness. So I think a lot of it is going to be played out at that level since we know what to do.
Yes, and we need to transfer that knowledge.
Yeah, go for it.
Yeah, for us, I mean, one of the things we've definitely learned working across the globe is that no community is too hard to reach, no country is too poor to innovate, and curiosity outshines fear every time when giving an opportunity. So I agree with you completely. What we're finding is the world has changed, and young people in every country want to apply technology to help public health. They want to be part of the solution. when this happens, the government, the political buy-in becomes part of the process because the organic nature of the help is coming from their own country. Unlike, what we've been doing in global health for the last 25 years is going in and trying to save everybody in these countries. Well, everybody in that country cares more about their country than anybody who's coming in from the outside. And that's how we're getting governments to really change, because this change is coming from their own technologists and from their own public health people. And that's really exciting.
And Steve, you were telling me some great examples yesterday of how PATH kind of works in the messy middle in helping connect the technologies with the people who need them, the health technologies, that is. Can you give an example of how you guys do that with, I think you mentioned meningitis or tuberculosis, one of those stories?
Sure. So for those of you who don't know, PATH is a large international NGO, but we're focused very much on innovation, and the innovation in global health, been around about 40 years. Work in 70 countries, and our kind of a bit behind the scenes often, because what we're doing is saying, look, there's a lot of great ideas in country, in academic institutions, out of industry, whether they be on products like drugs or vaccines or devices or tools, but also system innovation and service innovation, and it's coming from all around the world. But there's a long distance between those great ideas and the last mile. And people sometimes assume, great idea, you throw it over and somehow someone in the last mile catches it. And it just doesn't work that way. And so what we've been committing the last 40 years to is, how do you actually take great ideas and adapt them, evolve them so people have access. We're committed to that. Our mission is centered around equity, that we address this inequity because of that. So example was, we knew in one of many is in Africa there is a particular strain of meningitis A, the meningitis A strain that was just really devastating across the meningitis belt, sub-Saharan Africa, from say all the way Senegal to Somalia and even further south. And devastating on a yearly basis, neurological illnesses and deaths. And many ministers from that region said, pleaded to the WHO, we have vaccines for these things, we need one for this. And interestingly, we often in the case come together and form a coalition, a public-private social sector coalition, and led that coalition to get a meningitis A vaccine. And it involved bringing industry to the table, regulators to the table, manufacturers from India to the table. It was very much a global coalition. But the most important thing we did is based on the input, because the ministers and leaders from the African countries there were actually at the table designing this. It wasn't like, let's do that for them. And they said, you have to get this to 50 cents a dose from the beginning, because that's the only affordable mechanism. So we then started to reshape the scientific journey. We're mainly a group of scientists, to how to get that down to 50 cents a dose. A long story short is, 15 years later, we have that vaccine. It's registered. 300 million people have been vaccinated. No one has had a case who's been vaccinated. And we've essentially taken meningitis A off the table in that part of the world. Now, we have a lot more work to do to make sure it's integrated into all the national immunization programs. There's other strains of meningitis we're working on to create a pentavalent vaccine. But that was the example of saying there's a gap, but it takes a lot of work to go from, we know somebody has a patent around that, to let's make sure that we actually make sure the health systems and the leaders of the health systems are adopting it and making sure every community is getting it.
So I wanted to turn to kind of a more specific example. So I feel like Ebola was a big wake-up call for a lot of people in 2014. And I was wondering, what were the lessons that emerged from the international community's response to that? And have those lessons been implemented? And anyone can weigh in.
I can take a crack at that if you wish.
Go.
My view is that the battle against Ebola in West Africa was fought and won at the community level. There was a lot of international support. There was a lot of local government support. I don't want to discount that. That was essential to overcoming, to stopping the epidemic. But it was when the communities themselves got organized and started taking preventive measures themselves and practicing safer burial practices, for example, that we started seeing the rates go down. So that's a big lesson in dealing with the epidemics, is the community has to be at the center of the action going forward. As a result, a lot of the work that's been done on rebuilding health systems in West Africa and elsewhere since the Ebola crisis has focused on the community level. You know, how do poor countries afford the number of community health workers they may need in these remote areas, for example? So there is a lot of attention to it now at the community level. Well, there's a long way to go. There's a long way to go, but the focus at that level I find very encouraging.
But also, we have, this is the solution because there was a global failure. We doesn't have to forget it, because we need to create the global architecture for this to not happen again. And even if we go for building the community to make it work as a system, we need to create an architecture for that. And so, holistic approach, nationally from community to the top, but also globally. And there is a lot of work to do there. We need to help to reform WHO, really. We need also to reform the system of alert, really. We need to understand that we were late, really. But we need also to acknowledge that we are afraid because it's Ebola. But it's only, I'm going to say, malaria kills more. We have, I remember the picture of the New York Times with somebody from Afghanistan that has traveled 5 countries, passing the border of the US with a multi-resistant TB. You remember that?
Yes.
The world was checking because we can be infected. And after that, we forgot. And so many people are dying with that curable disease. So we need to rethink totally the way we look at a health system wider than a health system, and rethink also the governance of globally and nationally.
But when you say that, you know, that malaria does kill more, of course, but just for people who don't know every part of this, what is usually the cause for that? Is it because the malaria drugs are too expensive? Is it because people can't get to the clinic where they're distributed? Is it because bed nets aren't available? What is typically the breakdown?
We need another session. It is, and it's a pity, global warming. With increasing temperature, mosquitoes reproduce more quickly, bite more, and it is because of a lacking of the community system to save people. And having the test, like I'm going to take the example of Rwanda because this is the one I know the most, but it's like that all across Africa. We have 10 times more malaria cases today than 5 years ago. Mm-hmm. Okay? Dramatic. Because we had 265,000 cases a year, now we have more than 2,500,000. 2,500,000 tests, 2,500,000 drugs. It sucked the economy. So that means globally, we need to think more about global warming and give each and everyone a hand to solve the problem. Because mosquito has no border. So even if we solve the problem in Rwanda, a mosquito flies 4 kilometers a day, lives 28 days, and he crossed Rwanda from Uganda to Burundi during his lifetime and do babies all along the way. So a lot of things.
Yeah, and I would add, we work extensively on malaria, and it's a very complicated but tragic disease. I mean, besides respiratory and diseases and diarrhea, it's the 3rd biggest killer of kids in the world. It's devastating to the African economy, and it's also about, we estimate 600,000 to 700,000 kids a year die, or people die of it. The other part, I agree completely with Dr. Agnes. It's the change in vector and control, but it's also there are multiple dimensions that all have to get hooked together. And we've sort of taken for years this sort of test and treat if someone has a fever, maybe, if you're lucky. And what we miss is that 80% of people who have the parasite aren't symptomatic. So we have all these people that aren't, and so we're beginning to think about vaccines. We've been working with GSK on the first ever new vaccine in this area. We have to take it beyond the first one, but with new types of better drugs that are easier to equip, better diagnostics and get them cheaper. But it's really the operations at the community level. And one of the cool things, which I would say is another big trend, is we now have these data mapping tools and data tools so we can understand better where these things are happening, what the dimensions of the catchment area were. And we're actually seeing in some parts of like in Zambia, southern province, we've seen 92% reduction in malaria cases because we're using new operating models on the ground. So I think there is some hope there with all these things coming together.
Absolutely. So we know what to do. We know how to do it. We know that we need to start to strengthen the community. We know that we have to create systems.
And Mark, I wanted to get to you, but also can you tell us a little bit about, speaking of data viz, about surveillance tools and what we're seeing in that space?
Yeah, and some of the lessons also about Ebola I'll tie into that. I mean, one of the things we're finding is countries need to be connected directly with their neighboring countries in a way that's different from the formal structures of WHO and the regional offices. We're talking about neighboring countries who can be there, to help stop the spread and to provide resources in a informal sort of, we know exactly who to talk to across our borders. And we were inspired by the Rockefeller Foundation years ago when I was at the Nuclear Threat Initiative, because they had started a network between the 6 countries of the Mekong Basin. And I remember going to that meeting for the first time and seeing how, Laos and Cambodia and Thailand and Vietnam and the southern provinces of China and Myanmar were all sitting at this table, meeting on a regular basis, knowing exactly who their counterparts were in those countries. And so when something happens in those regions, you have a better chance than what we saw happen in West Africa. And it's much to our chagrin as a foundation. When we started in 2009, we identified that the 2 regions in the world that have no cooperation is South Asia and West Africa. And, we're a foundation of less than 20 people. And so we prioritized and we chose South Asia thinking, statistically speaking, and the number of people, and India alone, and have really worked to try to bring those countries together. And then lo and behold, West Africa and Ebola. The good news is there's lots of efforts now to build that regional network in West Africa, and I'm happy to say this November, Afghanistan, Pakistan, India, Nepal, Bangladesh, Bhutan, Sri Lanka, and the Maldives are all coming together to formalize the first regional network in South Asia, because that's going to be really important for surveillance. What's happening is in each of these regional networks, we're able to build surveillance systems that are culturally relevant from each of those countries, but at the same time, they're building it in the same sort of standards with their neighbors. So if something happens, they can communicate directly even though the systems are being built independently for their countries. Yeah. So I think that's how we're gonna really solve the surveillance issue, is really global health surveillance will become a connection of the mosaics of these individual, even within a country. I mean, if every community wants to have specialized surveillance that then feed into a national, that then feed into the global, I think that's how we're really going to get a handle. And the mapping is just incredible. I mean, that's what gets everyone in these countries inspired about what's possible, because, in Thailand, for example, 80% of the population have 2 smartphones. Even in Cambodia, they're getting close to 80% of the population having smartphones. So we're seeing a chance to really geolocate any disease reporting. And even if it's not in a smartphone, we're doing a project in Cambodia where they have a hotline that we worked with every telecom company, so it's completely free. So if you live in Cambodia and you want to report anything, you call 115, and it doesn't matter what phone you have, it doesn't matter who your provider is, and that same system is used for disease surveillance by the officials. So they now report at the end of their workday through that same hotline how many cases of anything they saw, and it's all mapped. So for the first time now, the Ministry of Health every day sees if there's any like fever outbreak. And we never had that before. You know, it'd be so long, and then later on we'd figure out retrospectively, oh yeah, there was probably an outbreak 2 months ago. Now they can at least see, even with the absence of diagnostics and laboratory capacity, at least if there's an acute event, we can always try to find the resources to help them identify what that is.
And I wanted to ask about something that is sort of a emerging, it's not necessarily a health trend, but it's just a trend in the world, which is that we have more refugees now than at any time in history. And I know that a lot of that is because of climate change and because of instability in those nations, but how is that changing the health picture of the affected countries?
I'd like to take that for a moment because that came up in the incubator. Everybody talks about the last mile health, and we think about that literally and those really hard to reach populations. But part of that last mile are the refugees and the migrant populations because they're not part of an official system. And what's really been exciting is using mobile technology. People are figuring out ways to actually engage migrant and refugee communities within their countries because there's ways now we could do it to still protect their identity, but at least connect them in a system where you could almost think about creating an electronic medical record for each one of those individuals that then they keep. And so that's at least helping us make sure that we can still think about vaccinations and other preventive measures, but it's a really difficult group and unfortunately keeps growing.
Something that is important is that the lack of health in refugee camp is a real global threat. It brings cholera. It bring to the surrounding of communities. It's a danger. So we teach how to manage it, and there is a way to manage a refugee camp, respecting why they are refugees, their culture, but also how to organize the camp for themselves and how to take the people educated in that camp, transform them quickly in community health workers for rapid detection, rapid treatment of the displaced people. So we know what to do, and we have decided to do that through education. Like what you say, it is fantastic, but it should be taught in each and every health science institution so that doctors, nurses, dentists, sociologists know that this exists, we can help create it.
The refugee migrant problem in health is immense, and we've been looking lately at, for example, what Steve was mentioning earlier of child mortality. How do we reduce those numbers going forward? Well, almost half of the cases are in conflict zones. So if we're really going to bring that down, that number down, along with maternal deaths, we need to figure out how to provide for some modicum of care in those conflict zones. I don't know the answer. I think we're all struggling with this. One thing that's a trend, if we're looking at future trends on this, Olga, is that the UN Refugee Agency, UNHCR, is trying to move away from refugee camps as the solution to refugee problems. Now, there will always be refugee camps in the world because governments want to keep the refugees away from the general population very often. But let's assume that in the future, the number in camps will be less, which means that the refugees themselves are dispersed within the general population, probably largely in urban centers. What that means is that the stress will be on the local health system. And we need to be thinking of ways of, if refugees are our future, will continue to be our future, how do we strengthen local health systems to develop that capacity and that resilience that when the flows come, they can handle it. An example that I think about is Lebanon. With the Syrian refugee flow, a quarter of the people in Lebanon seeking primary care within the Lebanese health system are refugees. And so they've had to figure out, well, how do we absorb this? The same with their schools and other institutions.
And two quick additions to this. I was a former UNHCR guy, but two areas of this is the political and financial dimensions of how the refugee crises and are sitting next side by side with health and development, and that's a very complex story. And I just want to note that even the way OECD funding is calculated gets very complicated. So that's actually a piece of the story. But another piece of this story is that sort of internal movement of people is actually one of the other big phenomena that we continue to see. I mean, the global health system and architecture was fundamentally designed around the rural poor. And because that's where most of the poorest people of the world were, and they're still, but increasingly, the most challenging and displaced communities are actually migrating into cities with the urbanization. So the other kind of component is we're learning quite a bit of, okay, what happens when people are moving from Bihar into Mumbai and back to Bihar, and bringing things back and forth, and how do you manage that? And that's actually, there's a lot of new programs and ideas of how to support governments in that area, but that actually has some lessons that I think we're beginning to see in the refugee situation as well. So it's kind of an interesting overlap.
And then one thing I really wanted to ask about, which is not something that we often think about when it comes to global health, but the rise of things like obesity and smoking in countries that aren't America, even in middle income and lower income countries even. I was wondering, what are the populations within those countries that are most affected, and sort of why is that happening?
Well, I'll start. I mean, I meet with ministers of health on a monthly basis around the world, and they talk maybe a little bit about Ebola or whatever, but the number one conversation we're having is about NCDs.
And just really quickly, NCDs, what does that mean?
Are non-communicable diseases, which is diabetes, stroke, cancer, hypertension, respiratory. I mean, the things that are chronic and that are actually, the burden of disease show it's killing far more people in the world outside of sub-Saharan Africa in every country. The big thing here is it used to always be thought of as diseases of the affluent. And now we're understanding better and better these are disproportionately affecting poor people, so it gets back to equity. And we have a lot of work ahead to work on. We're doing a lot of work on diabetes management in very low income settings around the world, but it's a very large, talk about a trend that we've all got to grapple with. And right now, there's lots of sort of random efforts. That's probably belittling them too much, but there's not a cohesive set of activities. There's no large funding bolus. This is a large conversation we got to keep working on.
This is a wide open space for action, too.
I agree.
If we're looking at trends of the future, where even in sub-Saharan Africa, where it's something like a third of the incidence of disease is the non-communicable sort right now, but that's going to be up. That's going to be up to almost half by 2030. So it's a serious problem.
So in fact, there are great action done for infectious disease. We have the vaccine, we have Global Fund, we have PEPFAR, we have a lot of foundations that are focused and successfully. Successfully. Countries that are organized have access to Global Fund, PEPFAR, and vaccine. Now, the life expectancy has increased. With economic development, you enter with salt, sugar. The big issue, I don't want to name some Mac something, that are the symbol of improved economy, wealth. If I want to show that I'm rich, big car and a Mac something. So we are destroying the health of the people. Yeah. And we know it.
And the environment, too.
Absolutely.
Where a third of all strokes now have air pollution-related respiratory.
Really?
And,
yes.
Wow.
And it's not enough said. It's not enough, because even if we stop that, we are going to reduce by 50% the risk of all those non-communicable diseases. They were always there. It's just because people die less of some infectious disease, and because also of a better wealth, that the population are suiciding themselves.
Huh.
No, I said, well, first of all, let's just stop exporting cigarettes around the world. That would be a very good first start. But I agree with you. It was so. My tuk-tuk driver in Cambodia, when they opened Kentucky Fried Chicken, And he was like,
He said,
thank you so much for investing in our country. We're so happy. And I'm thinking, yeah, not exactly probably what we should be investing in, but yeah, I mean, it's exciting for these countries to see things that they, emulate wrongly in some of the wealthy countries, but it means something to them to see their countries developing and growing. And yes, we want to support new jobs and new businesses, but it's kind of ironic that the new jobs and new businesses we see are exactly the kinds of things that are leading to the NCDs.
But there's multiple dimensions. I mean, there's the prevention space, there's the political space, because there's a lot of actually smoking we've seen at tax policies, et cetera, that can affect it. It's so many dimensions. But I think on the solution side, and I've been sort of obsessed with this, and I've been doing a lot of work in this area lately, is one of the things that we keep hearing is, well, industry will solve this, because this is a rich world problem as well, and so we'll start designing, implement interventions that work, and then they will trickle down. I mean, trickle down to the poor, and it's like, what part of the last 40 years did you not understand that things don't just trickle down? We've got to design and think about specific interventions. So I think we have a lot of work to do to get to action in this area.
And a lot of sensitization. I'm going to tell you a joke. We give some chicken to poor family to fight malnutrition so that there was 1 egg a child a day. And the father took all the eggs and went to sell that to buy Coca-Cola because you have Coke on your table and you are healthy. So
You said it. Yep. You said it, Coca-Cola.
yes. So I hope, sorry, but it's just to tell you that there is something that it's twist. That is twist in the way people see what healthy mean.
Yeah.
Healthy mean you.
Yeah. I think we have time for a few questions. If you guys have, I think back there in the blue, you were first. I think there's mics coming around so people can hear you.
So I cried.
Thanks. My name is Evan Lee from Eli Lilly and Company, where I lead Lilly's global health program. So we have a number of programs working on NCD care around the world. So I challenge some of what has been said in terms of we know what to do, because what we've seen is that even in upper middle income countries, health systems struggle to make the pivot from acute episodic-based care to chronic care, to manage the journey of the patient throughout the system. And so while certainly prevention is certainly part of it, there's still an estimated 400 million people with diabetes who will need care. So I think there's a lot of scope and need for innovation in healthcare delivery. So in terms of also just one of the other points you made, and here's my question, as there's no PEPFAR Global Fund, and people talk about multi-sectoral partnerships, including working with the private sector to address NCDs, and I hear that a lot in Geneva, where I'm based. The question would be to any of you in the panelists, how do we get beyond the talk and the lip service that's paid to multi-sectoral partnerships to actually having these work to address some of these challenges?
Well, first of all, I was by no means saying we know how to solve NCDs, and there's innovation on all sides. It's just we've got to think about it, prevention, treatment, in all different types of communities. Look, everything we do in the world I work in is done multi-sectorally. We work closely with governments. We have almost every project, we have industry partners. We have no presumption that we should be in the business of manufacturing, distributing. We don't have, and so I think that I actually would push back that there are actually great examples of this isn't just all talk. Every day we're entering into new public-private social sector compacts to address, chronic diarrhea, to address a number of things. So I think there's an opportunity for now. We need to actually go beyond one-offs. I think the problem is they're kind of one-off and they run for a while and then that's the end and they wrap and then everybody talks about it in their marketing brochure, versus how do you create more strategic, ongoing capacity and sort of a portfolio model of a multi-sector engagement. And so we're working very hard on that. I think there's lots of opportunity, and we're doing it with pharma, with high-tech companies as well. I mean, it's not just pharma that's part of the solution anymore. I mean, this is with agricultural companies, and it's with the data and media companies. So we've got to get even cross-sectoral that way as well.
So, and it's not only to do something great, it's to implement it everywhere.
Yeah.
And that's the problem. Implementation science is overlooked.
Yeah.
Is overlooked, and what people come and say, oh, you do that so well. Okay, let's go and this best practice and go there and put it. And it doesn't work because it's not the same culture. So there is an implementation science that we should recognize so that all those great innovation, great partnership can flourish across the world. And also, whatever we do, even if there is PEPFAR, Global Fund, and those things, strengthens health system. Never forget to ask, in this specific country, what is the best way to care for the poor? Then you strengthen that. In some countries, it's public. In some other countries, it's other. Nothing is replicable. The only thing replicable are the good principles behind it.
As I said at the start, I think multi-sectoral action is absolutely vital to deal with the challenges of the future, and that includes private sector. So that just to state that. One thing that we have found at the Rockefeller Foundation that's the most productive kind of partnership that's public and private is not when we're looking at the money, although we all want money, into the system, better financing. But the private sector capacities are awesome. So when we're thinking about an approach, if it involves supply chains, well, private sector entities know a lot about supply chains, can help with that capacity. If it involves better communications or IT records, electronic medical records, those capacities are what's needed in addition to the various products and innovations that the private sector brings.
Any other? Let's see. In the gray or beige jacket, right there. Yep, you.
Good morning. Thanks for the great discussion. Sticking with the NCD question for a moment, we heard some mention about the great successes of the Global Fund and some of the, let's call it DAH, external financing efforts to address pandemics, epidemics, infectious diseases. I've been in the NCD community for a lot of years, and one of the mantras is there's not going to be a global fund for NCDs. And I think, Steve nods his head. Everybody agrees because it's a different world now, and we're in different times, and your discussion is reflecting that. I'm working with a group of people who, Dr. Agnes was involved in the Global Health 2035 Lancet publication, and we're now taking a closer look at NCDs because that work focused a lot on the convergence agenda and getting to the end point of maternal child health and infectious diseases. But the NCD agenda, of course, as you've said, it's very big, and what we're struggling with is, or thinking about is, what are the collective action opportunities for addressing NCDs? If we're going to say the global community probably doesn't have a lot of new funding money or institutions, perhaps, at least not right now, for NCDs, what should we be doing that provides public goods, global public goods or collective action goods, that there may be more energy behind than providing individual services, drugs, et cetera? So if anybody has any thoughts on that, it'd be great.
I'll just make a comment on something that's probably going to be quite controversial, but I heard this is what you're supposed to be saying at Spotlight Health. You hear people all the time say, healthcare is a right, not a privilege. Maybe we ought to be saying healthcare is a right and a privilege, because I feel like we take away the personal responsibility. So yes, you have a right to healthcare, but within that right, it's a privilege to have that. So you need to also exercise, not smoke. I feel like we've taken away the individual responsibility in some way by just saying, yep, okay, well, do whatever you want. When you have a heart attack, you show up at the hospital and you have the right for all the treatment and so forth. Absolutely, I don't disagree with that. But somehow I feel like we've removed the personal responsibility by not also saying it's a right and a privilege.
And you know why? Because we don't involve communities enough, even in prevention, even in treatment, even in building a system. When you explain and you involve them in building your pyramid of referral, etc., they will be the first to say, okay, let's avoid people to go there unnecessary because it's a cost on all of us. And they start to be involved.
And I think I'm actually would agree with that we've got to balance those things. Although, certainly the predeterminants that end up involving very vulnerable people having NCD cases are often beyond their control in many instances. So I think we have to be somewhat careful with that. But there are some new things. I mean, we're actually thinking about sort of drug financing mechanisms that you could create supply better. There's some really interesting work done some work on diabetes case management, where we can start understanding better how to unlock the supply chain. There's a very interesting project we helped do where PEPFAR and AstraZeneca, we've helped bridge that, so at least you have hypertension screening in the clinic at the HEPFAR. So I think we're beginning to start figuring out opportunities where we can bring people together, but I would go back to Dr. Agnes's point, it's got to be community driven, and because these are chronic, complicated things, and the top-down approaches might help create a better supply chain, but it's not going to get to the solution we need.
And we did a study that showed that we have reduced by 40% the death due to non-infectious disease only by tobacco law, tobacco stigma, putting helmet, putting the seatbelt, and pushing people to take their blood pressure once a year, and things like that. 40% without almost doing nothing. Okay? So involvement of the community, but with knowledge and understanding, and stop to be a paternalistic, educated person coming from I don't know where.
But I guess, so just to follow up for you about the personal responsibility, how much of that is just not being able to afford the right kinds of food that would prevent obesity or diabetes?
Oh, sure. There's lots of issues. I don't mean to say it's an easy solution, but I think it's also just a message that, we need to be part of. I agree. Let me give you an example. There's a province in Thailand called Serapi, and the medical director, who is really interested in a systemic approach, said, wouldn't it be nice if I knew everything about every household in my village? So they contacted Google, and they said, would you be willing to do Street View for every village road through this entire community? And then they partnered with True Telecom because the director said, and I want every household to have 3G access so I can be communicating with them. So they did it, and they mapped out this entire community. And within this, now the medical director can look at the house, a picture of the house, knows everybody who lives in there, every health condition, knows where their food comes from, where their water comes from. And what was interesting is, after they completed this whole project, they realized that there were 100 farmers who were practicing organic farming. They had no idea. Because of that, they created a coalition, and now 1,000 farmers are practicing organic farming. This was a system they built for disease surveillance, and now it united organic farming. So the point was, to the community, it didn't matter to them. They were just empowered to think about the health of their community. So, they're eating healthier, and they're exercising, or they're doing things because all of a sudden the community feels united. And I think that's how we're going to change.
Okay.
Multisectoral.
Yeah.
There you go.
An example of that.
Well, unfortunately, that's our time for today, but thank you so much, Steve, Mark, Michael, and Agnes, and thank you all so much for being here. Please give them a round of applause.